Welcome to State of Reform's virtual series, 5 Slides We're Discussing, with some of healthcare's most thoughtful leaders. And now, the host of State of Reform, DJ Wilson.
Hello and welcome to another edition of our 5 Slides We're Discussing series. This is one of our virtual conversations that we started almost a year ago as we have all been going through this pandemic space together here with COVID. My name is DJ Wilson, one of the hosts here at State of Reform that works to try to bring these opportunities where left and right and public and private can get together in a now metaphorical room to talk about some of the issues that are really top of mind for folks both in the market space and in the public policy making sector as well. Today we have another free event, of course, and the reason these are free is because we have some pretty cool, smart, fabulous sponsors doing great work. We have 3 of them for this show. One of them is Signify Health, which is an analytics and networking platform that is useful for value-based care, connecting providers, plans, and community-based organizations across their network to drive value out of healthcare. Another sponsor is Community Health Plan of Washington. They've been around in Washington State for over 20 years, built together from the collaboration investment from community health plans, from community health clinics across the state as part of the Community Health Network. And then finally, Kaiser Permanente of Washington. Of course, Kaiser, is one of the top rated Medicare plans and one of the highest value commercial plans, not just in Washington State, but everywhere they touch in the country. Their quality and cost scores are really top of class. So those are 3 great organizations, both in terms of value and in performance, and we're super honored that they are putting wind in our sails. So before I introduce our guest here today, I want to just orient you, if this is your first time, we have this, of course, chat box on the right, and you can go ahead and post your comments there. We've got about 240 folks registered, and we usually get about 75% of those folks who are in with us at any one time. So go ahead and post your comments and your questions there. And then as you do that, you'll see there's a little thumbs up icon that you can click. And when you click that, it will prioritize or upvote all of the comments that people like the most. That way I can see the ones that kind of rise to the top, and I can make sure that those get integrated. I'll pull those into the conversation as is allowed. So, and if you have a question or something dawns on you a few minutes after we've talked about it, don't be shy. You can jump right in, and I'll try to get that integrated as well. So again, without further ado, let me just jump right in with introductions. First, Donna Sullivan, who is the Chief Pharmacy Officer at the Washington State Healthcare Authority. Donna, thanks for making time to be with us. Tell us a little bit about the work you're doing at the HCA.
And I hit the wrong button. I'm sorry about that. I hit the camera button. This is Donna Sullivan. I'm the Chief Pharmacy Officer at the Washington State Healthcare Authority. So I manage the Washington State Medicaid Pharmacy Program, as well as our public employees and school employees pharmacy programs within their health benefits.
So both your commercial like public employee lives and Medicaid. Thanks for being here, Donna. I appreciate it. Yusuf Rashid, who's the Vice President of Pharmacy at Community Health Plan of Washington. Yusuf, thanks for being with us. Tell us about the work you do at CHPW.
Thanks, DJ. Thanks for having me here. Yes, I'm a Vice President of Pharmacy, Community Health Plan of Washington, where we have managed Medicare, managed Medicaid, and a commercial exchange product. We're a regional Washington health plan, as you mentioned. We are formed by the community health centers in Washington, who collectively formed CHPW a good 26 years ago now. And we support community-minded providers in the provision of whole person care, physical and behavioral health care to the members we serve in Washington. Thank you, DJ.
Yeah, thanks, Yusuf. And Megan McIntyre, the Director of Pharmacy Business Services at Virginia Mason Franciscan Health. Megan, thanks for being here. Tell us about what you are doing at Virginia Mason.
Yeah, happy to be here. So I'm the Director of Pharmacy Business Services, as mentioned, and I sit in a position where I get to leverage with the eye towards quality and value on both the pharmacy purchasing acquisition down to how do we use it, revenue cycle, and then also kind of running it in reverse or from a different perspective, providing clinical leadership to our self-funded health plan.
Yeah, awesome. Thanks, Megan. And Wayne Weingarten, who's a senior fellow and director at the Center for Medical Economics and Innovation at the Pacific Research Institute. Appreciate you being with us, Wayne. Tell us about the work that you do.
Thank you so much. So glad to be here. at the center, one of our main goals is trying to understand this crazy drug pricing system that we have, and trying to, how do we implement policy reforms that are going to help kind of achieve the dual goals of continued innovation as well as broad-based affordability. And we do that through studies where we try to understand and explain how the drug pricing system works, what are the different components of it, as well as the types of reforms that are necessary that would actually help achieve those two goals of innovation and affordability.
Yeah, very good. Thanks, Wayne. I appreciate it. This is in some ways a perfect panel for us here at State of Reform. On the one hand, we've got a great set of speakers from very different perspectives, local, national, different silos. It's also, I think, a topic that exists at this intersection of where we have been, where we are, and where we're going. In previous conversations about pharmacy and RX, the focus had been, prior to COVID, very much on cost. And of course, during this period of the pandemic, folks are focused on things like getting vaccines and access and innovation. So where we're heading is it's a real sort of open question. So we're excited to dig in here with our folks. So let's go to this first slide. It is not a straightforward slide. Donna, tell us about the slide that you've brought and why you've brought this to the conversation.
Sure. So one of the reasons, or one of the questions often that I get is, how are drugs purchased, within our healthcare system? And my answer is usually it's very complicated. And by this slide, this is a very simplified approach. We really have three main components in the purchasing distribution model. You have the purchaser, the manufacturers, and the pharmacies, and then the patient-provider relationships. So we have employers or Medicare, Medicaid programs that are purchasers. They usually contract with a health plan, who usually has a contract with a pharmacy benefit manager. And then we have manufacturers who are developing the drugs, setting the prices. They're negotiating discounted prices through group purchasing organizations or wholesalers, and then those medications get dispensed or get sold to pharmacies. And then we have patients that are members of the health plans. They see their doctor, they get prescribed a drug, they go to the pharmacy and get their prescription filled. The PBM pays the pharmacy for that prescription drug. The pharmacy benefit manager also is negotiating rebates with the manufacturer, and then passing those rebates back to the health plan. So it is a really complicated area, and one of the reasons why I like this slide is it just shows you how difficult. There is not one solution to lowering the cost of drugs, because each one of these pieces kind of takes a bite out of the pie.
It's a little bit convoluted. Megan, what do you think when you see a process map like this one?
To me, I see a lot of opportunity, I guess. So it is really complex, and that should make us all stop and go, who stands to benefit? What opportunities might exist to either influence in terms of patient outcomes or cost savings or revenue generation? And I think it's really important to consider sort of the stakeholders at each of those transaction points and what would motivate them, and realize that we all have at some of those distinctly different competing priorities about what we want to see, and how do they influence something maybe further downstream.
Yusuf, one of the questions I have, and I'm not a pharmacy RX specialist by any stretch of the imagination, but when Donna talked about just transactions and rebates, health plans sometimes get rebates, FQHCs definitely get rebates, hospitals definitely get rebates. Why do we have a system that doesn't just put those rebate dollars into the pockets of patients?
That's a great question, and when you think about it, it's a bit of a bubble that gets pressed, and when the rebate comes in, does it hit the patient's pocket directly in their copay or their coinsurance? Sometimes it does. Sometimes it might be reflected in lower premiums that the plan's able to pass on when they receive the rebate, and it is very distorted in that sense. And I don't think there's a straightforward answer for exactly which rebate benefits the patients directly and the most. But part of the challenge is to align incentives and align cost and payment in a way that it creates more clarity to where do the rebates go and who do they really benefit.
Yeah. So Wayne, I know you focus in your research on the importance of competition in markets like prescription drugs. To Yusuf's point, it feels like sometimes competition in one space just pushes pressure to another space that may be less competitive. How do you bring competition to a map that looks as complicated as this one?
Well, I think one of the interesting things was this is a simplified version of the situation, so we recognize that. And I think Yusuf said it best when he was talking about aligning incentives. Part of the reason competition is struggling to control drug prices right now is because the incentives aren't aligned. And so when people are acting, either when you're one of those intermediaries, your incentives, if it's not aligned with the patient, often it won't be. That's why we're getting a lot of these really troubling outcomes, especially where you have right now the situation where the actual net prices for medicines, right? The prices net of those, all the rebates that are paid and all the concessions that are paid, those have been going down for 3-4 years when you look at the actual net pricing data, but costs for patients are going up. And those patient costs are going up because their costs, they don't need to be, but they are tied to the gross prices or list prices. So all of this creates that misalignment of incentives, and that complicated system is what enables this to happen. And so if we're going to actually get a system that makes sense, the first thing we have to do is make sense of this complicated chart and simplify it.
So Donna, gosh, you're the government. I know how funny that sounds. There ought to be a law, or, if you were, obviously your job at the healthcare authority is to implement the law, not make the law, but where are the sort of primary points of friction that you would suggest the market or policymakers look at in this system, this oversimplified map, as you called it? Where are the primary points of friction that seem like the lowest hanging fruit for reform?
I think the biggest challenge we have with this system is not only is it complicated, but it's opaque. We don't have the transparency into, we don't know what the rebate agreements are between a pharmacy benefit manager and the manufacturer. We don't know what does the manufacturer consider when they are developing the cost of their drug. How do they come up with a $2.1 million price tag on a gene therapy? What are the discounts that they're offering to the different, group purchasing organizations or large, facility purchasers, hospitals? It's just really opaque. So in Washington State, we have the Drug Price Transparency Program that was passed 2 years ago, where we are actually trying now to reach into this complicated process and try to pull out some of those elements.
Yeah, complicated indeed. Let's go to maybe not less complicated, but at least a little more simple looking slide. Megan, you can tell us about your slide that you've brought and why maybe simple may be the incorrect adjective.
Okay, so it has a couple different images on there, and I want to start with the quadruple aim, really, I think, to center us all. I don't think anyone here is going to disagree. I guess I welcome the conversation if you do want to disagree with the pursuit of the quadruple aim, and I'm being really intentional about pulling in the quadruple aim versus the triple aim as we have now passed the 1-year mark of COVID. The addition of improved care team well-being and the cost and impact on quality of physician and care team burnout, I think, is going to be even more important now than when it was sort of initially proposed as a key element a couple years ago. So, when I think about the cost of burnout and losing good providers, and the topic of this presentation was around innovations in bending the cost curve, and I put a couple of questions over there underneath my pun, and I'll get to why ice cube, a stick, and a carrot showed up on my slide. And no, it's not like a bad joke that they walked 6 feet apart to an outside coffee shop or something like that. But, whose cost curve are we talking about? Is it really innovation, or was it a stick because we had to? What incentives are out there, and are there things we want to have stay? And so the ice cube is alluding to the change model by Lewin. I'm a nerd in change management and leadership. So the freeze, unfreeze, refreeze model. So right now we're kind of in an unfrozen time, right? So you could take it further and you could say, what should we melt away, right? What do we want to refreeze into this system sort of after COVID? We've been given almost a gift in some ways, where we've had like a punctuation to really move forward healthcare with some, you think about telehealth, right? And I know for our system and many others, what we achieved in a very short time to deliver telehealth services, previously would have taken a lot longer of a work plan. There's some quote unquote innovations, I think, in pricing and products that are out there, but I think we could, kind of have a good conversation about if they really were innovative or not. And so then what do we want to refreeze? And I think that we should make the most of it and remove some of the sticks. Think about how to make them into carrots, right? How can we incentivize this focus on value, achievement of the quadruple aim, and then hopefully move them into more of like a status quo, like it's just the way the system works versus sort of standalone incentives.
Yeah, good. Yusuf, what do you think about this idea of sticks and carrots, but the incentives that health plans have traditionally used to manage utilization or manage and coordinate care, and how some of those traditional uses may not apply, or maybe they do, but maybe they don't apply very well to the pharmacy space? What do you think?
Yeah, that's a great question, and I love the analogy, Megan, so thank you. I first want to comment that we are always, as healthcare as a science, evolving, but make no mistake, this is an revolutionary time for healthcare in terms of innovation. And I love that concept of this is our opportunity to freeze what works, but maybe it's time for some things to melt away, as Megan is describing. As far as the slide and the suggestions, I do think that this is a time to align incentives around concepts like the quadruple aim versus siloed stakeholders potentially chasing after a rebate like we described earlier. How do we take this opportunity with all the vertical integration through the system as well, where individual organizations can touch so many aspects of care? How can we create value-based incentives that are aligned around concepts like the quadruple aim, rather than more short-sighted or myopic targets that individual stakeholders are chasing?
So, Donna, as you try to make heads and tails of this at the state, I have I will convey a cynicism that sometimes I think talking points reflect reality, and sometimes they reflect marketing. And sometimes knowing what's real and what might just be ether is a little challenge in healthcare. And I'm wondering where you see, from the view of the state, where you see opportunities, real opportunities to drive value and innovation in pharmacy.
That's a great question. We hear about these value-based, outcomes-based contracting is kind of like the new buzzword among, especially for rebates. What's really challenging with those types of agreements are the assessing the outcome. How are you going to measure an outcome of a drug when there can be so many variables that might impact that outcome? And we also have a challenge where manufacturers are not necessarily willing to put a lot of risk into not achieving that outcome. So the plan is really absorbing all of that risk. So that has been a really big challenge as far as how value-based purchasing in the pharmacy world is going. But if you're trying to look at what Yusuf was talking about, the entire healthcare delivery system, I think there are better outcomes with trying to get providers to be more accountable for the health of their members, rather than just working towards the fee-for-service type widget delivery system that we currently have. And I believe that, to Megan's point, telehealth has really, I think, allowed for that to occur, where you can just have check-ins as opposed to you have to have an office visit in order to speak with your provider.
So when you go ahead, yeah, Megan.
Well, I was just thinking about, we're having a conversation around value-based incentives, and I think it gets back to, as a provider, I put on my provider system hat, that a lot of times those contracts or, measures are based on things that as a provider we can't actually influence, right? And they were designed potentially by someone who stands to benefit regardless of how it goes, right? So I think about med adherence. And I should have maybe drawn a soapbox picture on my slide too to add to the allegory, but just filling a prescription more and measuring how much you have in your hand doesn't really mean that the patient's having a better outcome or adherent, but there's revenue that feeds back to somebody, right? And there's cost that's incurred by someone else. And so I think that even right now, if our value-based incentive mental model is a little unfrozen, we should really think about what actually makes a difference and who should have that incentive, that carrot applied to them. Like, where is the right place to put it and who's designing it? And I think it gets back to Donna's slide to really understand what does that do down here in terms of funding. And I can also, as a provider, say, a common thing is that, well, we fee for service, so we're incentivized to use a higher cost product, right? Because we get revenue. So you just start thinking about gross revenue, and you can see how all of that's there. And so I think, everyone, needs to really come to the proverbial table, recognizing both the faults in their system, because I still need to ensure that we meet budget and have revenue, right, in order to deliver care, if you will. But where can we meet and sort of, I don't want to say concede, right, because it shouldn't be a winner or a loser, but not understanding all of these different transaction points and the different perspectives, I think really weakens it. And a concern that I personally have, and back to burnout, is that from the delivery provider side, like, people are really tired, right? And so right now, are things going to be decisions and contracts and ideas and new programs getting bolted on that have consequences that either maybe we aren't able to even be aware of happening, right? So even within just a system, how can we ensure that we're removing, some paperwork? So I think about patients before paperwork. It was a 2017 American College of Physicians sort of initiative. Like, how can we do that, right? And make it simple, make it simpler, remove maybe prior auth as a blunt stick, and think about how to target and use it wisely. Because, put on my plan hat, I absolutely utilize that tool, and I can see where we need it. Like, it makes sense in some areas. So,
yeah, good stuff. Sticking with the theme of complicated slides, I want to jump into yours, Yusuf. You got a lot going on here. Walk us through it.
Sure. And when I was first asked to participate on this panel, I thought, how am I going to distill the complexity of this topic down onto one slide? And I started thinking about the conversation in terms of loosely structured around the qualities of an efficient market: transparency, competition, standardized, liquid. And with that framework, I started thinking about some examples that I wanted to share that are loosely connected to those themes of qualities of an efficient market, and comparing that framework to the prescription drugs and drugs in general. So with that in mind, a lot of the things have been echoed already. That's something that happens when you're the third slide, I guess. But for instance, with first of all, with transparency, prices do not reflect the costs that are paid by the seller. And we talked about prescription drug rebates, but this goes through the whole system. Again, to echo Donna's slide, that the patient paying, whether they have a copay or co-insurance, quite often there's an opportunity for a rebate for them through a copay assistance program from the manufacturer. The pharmacy, when purchasing the drug for sale from the wholesaler, depending on the type of pharmacy they are, depending on their purchasing arrangements, they'll have rebates that distort the true cost for the pharmacy. And me representing the payer on this panel, who pays a PBM, who then in turn pays the pharmacy for the drug that's dispensed, the connection between the prices paid by the payer and the costs of the seller, it's a carnival mirror distortion through the whole system that really makes it hard to get our arms around, creates a space for other players, rebate negotiators and aggregators, to potentially add more waste in the system that wasn't needed except to address the complexity and lack of transparency. I brought up an example here that is actually medical benefit drug, because what we just described previously was prescription drug benefit, but keep in mind, most of the highest cost biosimilar and biologic drugs now are on the medical benefit side, infused by professionals rather than self-administered by the patient from a retail pharmacy. And this is just from my own claims analysis, where one particular drug, looking at a given period of time, I saw a variance, $1,754 to $5,507 for this infused medication. And the general consensus assumption might be a home infusion would be cheaper than a facility hospital. But depending on the type of facility, I found there's quite a range, and that there's quite a bit of variability in the way prices are defined, depending on the type of facility that's providing the product, the drug, which brings me down to the graph at the bottom left of my slide there, and just the idea of standardization, and a very simple question to start with: are biosimilars cheaper? And the graph here, if you look at the blue line at the top there, that represents list price and inflation for drugs over time, a 15-year period. And the top blue line is a typical way that price would be anchored or defined through list price for Medicare and commercial payers. And over the course of time, there's inflation, say, around 10%. And the bottom red line there, think of that as Medicaid's price, because Medicaid's price is fundamentally different. The federal Medicaid drug rebate program gives an initial discount on day one, a cap to consumer price index, so an inflation cap over time, and a potential for a supplemental rebate. So Medicaid's price is just fundamentally different. And if you look after a few years, the brand name drug, their patent expires, a generic or a biosimilar enters the market. So the question is that biosimilar, that purple line in the middle, is that one going to be a cheaper option? For the commercial and Medicare, it seems straightforward. It likely is a cheaper option, but also depends on the rebate that they're able to negotiate with the brand manufacturer. For Medicaid, is the biosimilar going to be cheaper? In many cases, if you're going through several years of significant inflation, greater than consumer inflation, then probably not. In many cases, then the brand price is actually going to be cheaper than the biosimilar for the Medicaid payer. So the complexity there in variability in how we define price. Competition, too easy. 3 PBMs account for 70% of prescriptions by volume. 260 million Americans receive their pharmacy benefit through one of the 3 PBMs. And liquidity, I thought of liquidity in this case in terms of the pharmacy as the purchaser, the pharmacy purchasing the drug. And I thought about one example, but there's several, and take cystic fibrosis modulators. These are biologics that revolutionize the treatment of cystic fibrosis, absolute game changers for the patients with the outcomes they're able to achieve. And when these drugs are in studies or in trials before they're in market, they're available through dozens of cystic fibrosis treatment centers in the country. After they go through the studies, gain FDA approval, they're in the market, and they're available at 7 pharmacies in the country that are purchasing through 2 wholesalers. And if you're a pharmacy wanting to purchase this one of these drugs in a volume to take care of your patients that you need, good luck if you're not one of those 7. So those are just some examples that I thought would be interesting for the conversation around that framework of qualities of an efficient market.
Wayne, what do you make of this slide?
I think this slide demonstrates how important transparency is. Right? The idea that there are so many different prices for medicine, so we can't even figure out what the price is. And one of the ways I like to sometimes kind of understand what's happening in the healthcare system is take how we work healthcare and apply it to another market. So imagine if we bought cars in this way. I mean, how on earth would you be able to know what your car, how much you should pay for your car if it's priced in the manner that's described in this chart? Or how are car manufacturers going to better serve kind of car buyers when there's so many people in between, so that they're actually not serving the patients. Because in all of the mess that's in that chart, the most important thing has to be, how are we serving patients? How are patients getting better drugs that are either improving their health, and also accounting for the fact, and that's one of the things we haven't brought in to the conversation yet, is when you're spending money on a biologic, right, you're actually creating savings elsewhere in the healthcare system, because often you don't need other types of medical treatments, fewer hospital stays, fewer doctor visits. So, we have nobody that's actually really focusing on what's the total healthcare costs. And the way that all this convoluted system, and all of these kind of intermediaries is keeping us from having that conversation, which is impacting our quality of care. So I think what all this is demonstrating is that the transparency, and that's something Joseph said, and I think it's so important, that we're not going to get a better system until we get better transparency across the board, whether it's hospitals, whether it's drugs, whatever the case may be. One thing that we desperately need in healthcare is greater transparency.
I want to bring in this question from one of our attendees. Anirban Basu asks, and I'll direct this to you, Donna. I think you may have the best view on this. He asks, what tools do states currently have to differentially promote or restrict certain drugs based on evidence or comparative outcomes? Do states expect a bigger repertoire of tools in the future? Donna, do you want to take a crack at that?
Well, Washington State participates in a program called the Drug Effectiveness Review Project, where we have contracted with Oregon Health and Science University, and we commission reports for them to go out and review all of the evidence. Sometimes they'll actually do a meta-analysis or a network analysis of the available data, and we can get some kind of comparative efficacy across a drug class. So we use that as a tool. We're always looking for, additional tools. We also rely on the ICER reports that come out looking at, what is the cost effectiveness of a drug, and, what should it be, if it were cost effective, what should the price really be? We can always use more help trying to get down to, which drug should we be preferring. With this particular slide, it becomes challenging because often, as Yusuf mentioned, as the price goes up for some of these drugs that are nearing the end of their patent life, they get extremely inexpensive for the Medicaid program, net of the rebates and any consumer price index penalties that the manufacturer has to pay because they're increasing their price. And it pushes pressure on us to then want to prefer a brand maybe over its generic, but the pharmacy is unable to purchase enough of the brand because their contracts with wholesalers penalize them if their dollar volumes of brand name purchases get above a certain percentage, then their total price comes up. So it really does create a big challenge.
Yeah. Megan, Jill Semanek asks a question about how COVID has specifically impacted the quadruple aim. Since you brought that up, I thought I'd pose it to you. And she asks about COVID as a disruptor to the system, sort of the unfreezing that you're talking about, and how you think some of the disruption might manifest in downstream implications as we try to return to normalcy.
Yeah, well, that could go a lot of ways. So I think maybe our greatest risk is not finding the opportunity within this disruption that we've had, right? So sort of the outcome depends on what we make of it, right? And nothing that I say is to downplay like the sacrifices and how long of a year this has been, right? But has COVID given us, a chance to rethink about what does quality mean, right? What does cost effectiveness mean for treatments? How are we going to measure that? We've had a lot of therapeutics, touted and kind of come and go from favor, come to the market in a pretty short time frame, right? Getting lots of press, and like, how does that change sort of way as a society we think about it? I think there's a lot of opportunity there. I think we have had some point examples of reducing administrative burden, not necessarily in the pharmacy space, where we lifted that. So let's study it and see, like, did we actually, did it hurt at all to make it a little bit easier to do the right thing to get that done? And then I think we need to, recognizing what can we do as a system to reduce further erosion of well-being for our providers, right? So we don't have them, we're going to have an even bigger access issue, and the inequities that we've seen in our system are going to perpetuate. So I think, I think it really funnels through there. But the other, trying to think of another good example that would be there with COVID and I think
building
the
on
outcomes
this
is one thing that I'm a little worried about. And when I think about the cost curve, is that everyone needs to be extra savvy about understanding when we look at our budgets, right, in 2020 or our performance in 2020, there's like a big, even your stock portfolio, right, your retirement, it goes bonk, and then it goes back up, right? And not to be quick to dismiss that to COVID, because I think that one of the things that we're going to see is sort of this tail end of people that haven't been able to get in for their preventive care preventive care exams, right? Or have lost coverage, and now it's even more financially challenging for them to access care. And are we going to see more complex or cancer diagnosed later on, and this kind of increase in costs, and how are we going to be ready for that? So that was a lot of thoughts. Sorry.
No, that's okay. It was actually kind of it was a pretty tricky question. Let me ask you another one, Megan, that may also be tricky to answer, because I know you're not the provider relations lead at VM. But I saw a statistic, maybe I shouldn't believe everything I read on the internet, but I saw a statistic that up to 12% of providers were planning on retiring or leaving the workforce over the next 12 months. Are you seeing anecdotally folks on the provider side just walking away from this work?
I'm not going to speak for like what I see within my own organization, but when I think about my circle of friends or my network, and when you talk with people, I mean, some of it is, I think by nature, like what people are more like, no one's like, I love my job and I'm staying, right? We're maybe just talking about, did you get your vaccine or not? But I do believe, and I think that there's been, recently, I think I just heard something on the news, maybe in the last couple of days, that actually had some measurement of providers leaving the healthcare system, like leaving their practice, and what'll that do? And, while, I work in Seattle, we've got a lot of different types of providers, imagine more rural, communities and the impact that might have, or independent, practices that aren't part of a system. So I think you're spot on that they are leaving, and, what is that going to do, and why are they leaving?
Yeah. I want to jump to our next slide and give you a chance, Wayne, to tell us about the slide, but also, if you would, tell us what is a biologic and what is a biosimilar?
Absolutely. If I could just make one quick comment, I wanted to say the other problem with providers that we're seeing beyond people leaving is because of all the paperwork and other types of burdens, we're seeing a lot more hospital systems and providers get kind of gobbled up into the independent practice. And those types of facilities are leaving, and that's given that that's not by patient preference, but it's more by kind of the burden of the system. That's a disconcerting trend, and that's another way that we see this occurring, which is it's driving providers out, and I think it's scary to see how COVID will impact that as well. But switching to my slide, what I had brought, starting with what a biologic is. And Joseph was getting into this in his slide as well. Traditionally, we think of medicines as something that we go to the pharmacy. And some biologics you do purchase at a pharmacy, but typically a biologic, which is a medicine not chemical-based, but is based on biological processes. So it's either derived from or made in biological processes, not chemicals. And often these are going to be infused in a clinical setting. So when you're talking about a biologic, you're talking about, at this point, when we don't want a drug affordability problem, we're talking about biologics. These are very expensive medicines. I think at this point, they're accounting for over 40% of total expenditure on medicines, and they've been growing at expenditures have been growing double-digit rates. I think the number is about 14% a year over the past 5 years. So these are very expensive medicines. It's important to note they're also incredibly high-value medicines, when you talk about our ability to help cancer go into remission, that's largely due to biologics. When you're talking about our ability to better treat autoimmune diseases, psoriatic arthritis, and all of that is biologics. So we have very high value medicines, but they're also expensive. So when we talk about drug affordability, and Congress is consistently struggling with this, but what we don't see them focusing on is the drivers. One of the drivers we've been talking about is the complexity of the system. Another driver are biologics. And so how do we control the costs? One school of thought talks about natural monopolies, the idea that biologics, for whatever reason, are different than other medicines. And so we need to actually just have one provider and impose price controls. Based on my read of the evidence, that's wrong. And what you're actually seeing is it took a little bit of time for competition to occur. But competition, just like it did with traditional medicines, can bring down the costs of biologics. Talk about traditional medicines, generics are 90% of the market, and the vast majority of those sell $25 or less in cost. Biologics are going to be more expensive because they're a much more complicated procedure, but their competitors, which are known as biosimilars, are actually, that market's beginning to grow, and that they're actually selling for steep discounts. Those two concepts is what I'm trying to bring in on my slide. So there's two charts. If we look to the left, we're talking about what's the price discount. And so we're looking at, in each one of those, kind of compared to the originator biologics, how much cheaper are the biosimilars now compared to before we had competition? And you're talking about at least a third off and up to almost 60% off in some of the classes. What you're also seeing is finally back in 2020, we started seeing where the biosimilars exist, where they're currently competing, they're actually obtaining a significant market share. So that's when you look at the right-hand chart, where the lighter blue color is the share back in 2018, and then 2 years later, or actually 3 years later, what is their share today? Back in 2018, only Zarcio, which is in the filgrastim class, did you actually see a majority of share being in the biosimilar. Today, and the rest was pretty much de minimis. Today, you see that biosimilars have a good bit of share across a lot of these drug classes, and given that they have larger share and much cheaper prices, that actually is providing savings, which is demonstrating that competition can provide the savings that we're looking for while still promoting innovation in the future. And that's the crucial balance, and that's what we're beginning to see, so that biosimilars are an important means to generate the savings we're looking for and continue the amazing innovations that we've seen.
So Donna, when you see this stuff as a regulator and as a purchaser at the Healthcare Authority, what do you make of these charts that Wayne has brought?
You know, biologics and the biosimilars has been a really challenge, especially for Medicaid, and some of the every biosimilar that has come out, they're not interchangeable biosimilars. So it's not like a generic drug where there's going to be automatic substitution if it's dispensed at a pharmacy. So they're essentially, when they get approved, a biosimilar is just another brand name drug that has the same component as the originator biologic. And so oftentimes for the Medicaid program, because of, you know, that slide that Yusuf showed earlier, those biosimilars are going to be more expensive for our Medicaid program. And we, when we try to manage, especially physician-administered drugs, it becomes challenging because the physicians, the clinics, the providers are going to want to purchase the least costly products for them, but they might be the most expensive products for the purchaser. So we're really struggling on how to balance managing physician-administered drugs, these biologics, as more and more of them come out onto the market.
We have a question from Barbara Morrow and another one from Natalie Cardenas. If I got your name correctly there, Natalie. I just want to address it. They both ask about why a pharmaceutical representative wasn't invited to this or is not on this panel. And I would just say we did have a number of conversations with representatives from pharmaceutical companies. They did not want to be on this panel when we were building this panel. And then when we announced it here earlier this week, we did have people ask to be on it, and it was, of course, already baked. But we're happy to have anybody who would like to come and join one of our virtual conversations. We have an open door We work closely with pharma in a number of states. Washington State isn't one of them, but we'd love to engage folks and continue this conversation. So let me ask, Wayne, when you think about, I mean, you're working on innovation and reform efforts. When you think about other industries, you mentioned the car industry, but when you think about other industries that could be a model to learn from when it comes to pharma pricing and maybe reform in the healthcare sector in general, what are the industries that you think are most helpful?
I think there's a lot of industries because you're just looking for what's an efficient market. And so we have a lot of examples. Obviously, it needs to be adapted. And, as we were just talking about, there are issues between Medicaid, which is going to be different in the prices we're talking about, is for employer-sponsored plans and for Medicare, where you look at the average sales price data, there are tremendous savings differences. And the fact that lower priced drugs are impacting Medicaid programs differently, that's obviously something we need to address. So I think any of the markets where we have that kind of efficient, kind of transparent prices that focuses on the consumer, right? In most other markets, you can take something as simple as the local coffee shops, right? Where when the consumer walks in, they understand and can see all the prices. You can see, okay, what's a dark roast, espresso, let's say, small, large. You understand the attributes, and so you can actually make informed decisions. Now, obviously, healthcare is much more complicated, and patients aren't going to be able to understand all of the kind of different trade-offs that are involved, but that's what the providers are for. And so we need the providers to be able to stand in the shoes of the patients in many ways and be able to do what's best for the patient and have the right incentives that are completely aligned, as opposed to currently where those incentives get kind of disjointed, or the providers are overwhelmed with the paperwork or prior authorizations, right? Where prior authorizations, and I think it's a perfect example where a practice that used to be done for clinical purposes, right, has now become a budgetary rule, and so that's very problematic. Those are the complications and the lack of transparency and the opacity that is making the market not work correctly, and most importantly, making the healthcare system not work for the benefit of patients. And so I think taking those principles from other markets can help.
Ann Ladd asks you, Wayne, if you would be willing to share your data. Is there a place where, share the data on which your slides are based? Is there a place where people can go and see the data that you're referring to?
Absolutely. The price data is just the average sales price data that the Centers for Medicare and Medicaid Services maintains. So you just go there, you can download all the data over time, and it's just a comparison of current price to price before competition. IQVIA is the source for the sales data, and so all that data is there as well.
Make sure, Ann, that your computer is ready to handle opening those spreadsheets. I know those data sets are sometimes pretty large. I want to go to our last slide here. This is one that we've brought to the conversation, and we tee this up really just to elevate the continued public opinion in favor of continued reform and action on the healthcare, on prescription drugs in particular, within the healthcare sector. That across the board, no matter how you ask it, folks are still interested in having low cost, high access, high quality drugs that continue to support innovation. I know that's like the old joke that you have heard, that the way I say it, because you got to always personalize it. My old burger joint that I go to has up on the wall, our food is fast, yummy, and cheap. Pick two. Meaning you can't have it all. And in healthcare, sometimes we're lucky if we get one or maybe two of those things that we're all aspiring for. So I just offer this as a reflection about the road left to travel on reforming this sector. So as we draw near conclusion, I want to ask each of you, as you look out onto 2021 and you think about policy and you think about politics and you think about your personal life, I just want to ask you, Wayne, we'll start with you. What gives you hope about the future of 2021?
I guess I think spring coming gives me hope that things are warmer. We have the vaccines coming. We can, go outside and get back to our lives. So it's almost like the rebirth, and we can feel that happening. So the warmer weather, spring, with the vaccines coming, all of this feels like the end of the pandemic and in a rebirth for 2021.
Megan, as you look ahead to 2021, what gives you hope?
I feel really hopeful about the concept of stop doing. I think we can all think in our own personal life, maybe reflections on things that we realized that we could have, by being forced to stop doing it, now we can continue it. But I think that same thing applies to healthcare. So what can we stop doing? Maybe it's, removing programs and vendors and solutions that we're ultimately, we're paying a lot of money for and not getting value out of, and I think it couples really well with this conversation. So.
Good. Donna, how about you? What gives you hope for 2021?
I think what gives me hope for 2021 is it seems like the federal Congress has finally started the conversation about drug price, and not just that they might actually start making some meaningful change in the regulatory environment, because, the cost of drugs, anything that the state can't do anything to really control the cost of drugs. It needs to come from the federal government, and it sounds like they might finally start having some more serious conversations, but that's probably still several years down the road.
And Yusuf, what gives you hope for 2021?
Sure, and after 2020, there's a lot of hope. We are turning the corner. I had my second dose this morning at 7 a.m., so I'm glad that I haven't had side effects yet. And so COVID's gifts, even though COVID was terrible, there's some gifts here. Technology, innovation, and the light it's shone for us. In terms of technology, telehealth, and the access to telehealth and access to care for members in the way that they want, that is here to stay. And I think 2020 was a big push in that direction. Looking forward to seeing that grow out in 2021. The mRNA vaccines that came out in record time because of decades of biologic research that we're talking about, the high-cost biologic drugs, the mRNA vaccines from Pfizer and Moderna would not have been possible without that technology. So incredible new cures for more diseases to come. And that's we're just starting there. As far as this light that COVID has shone also on opportunities such as inequity in the healthcare system are really brought to the forefront now after COVID, and looking forward to policies and legislature focusing on that. And behavioral health and the importance of behavioral health in the healthcare system also, I think, magnified with COVID. And so those are, I think, gifts that COVID has brought us that we can look forward to in 2021. How can we continue building on our successes and also look for opportunities to improve? Thank you.
Good stuff. Yusuf Rashid, the Vice President of Pharmacy at Community Health Plan of Washington. Donna Sullivan, the Chief Pharmacy Officer at the Healthcare Authority here in Washington State. Megan McIntyre, Director, Pharmacy Business Services at Virginia Mason Franciscan Health. And Wayne Weingarten, Senior Fellow and Director at the Center for Medical Economics and Innovation at the Pacific Research Institute. Thank you guys very much for doing this. And for our audience, thanks for joining us. We will have this posted online at stateofreform.com. And of course, we have our first federal conference coming up April 7th and 8th. We've got almost 1,000 people signed up for that. And you'll hear from folks like Senator Murray, folks like Representative Kathy McMorris-Rogers, folks from the Washington State and Oregon area. So we'd love to have you with us. You can find that at State of Reform. Until next time, thanks a lot.
Thanks for joining us in this virtual conversation and for your support of our work at State of Reform.